I had to do that. So, yeah, I just wanted to say that Bill was in physiology department and graduated when?
2009.
2009. A PhD from Dr. Harris' lab, and then you went to University of South Carolina, right?
That's right. Yeah.
As an assistant professor, and then moved to University of South Carolina School of Medicine at Greenville.
That's right. Yeah.
So that's, you know, when I realized that he's coming to town, I thought that would be a perfect person to talk to us about all the transitions he made.
Yeah. All right. So first of all, I want to thank you all for coming today. I was asked to talk on taking the teaching path, and so one thing that was important to me was to make sure that you're motivated to go through the teaching path. So if you are, then hopefully this information is going to be very helpful. But I'll kind of go through my history and my experiences first. How did I get into medical education? I'll talk a little bit about education in general, some undergrad, and a lot of my references will be from medical education, or at least clinical experiences. So even if you don't want to do medical, my undergraduate teaching experience was nursing school students. Okay. So first of all, a long time ago, I graduated with my bachelor's, and right after that I did a master's degree in exercise physiology. While I was doing my master's, I taught at Baylor University for a year and a half. So I taught undergrad students health education courses. That's kind of the first experience I have. I fell in love with it, so I wanted to continue doing education and research. But for a while I got out of it, and I was a clinical exercise physiologist for about 7 years. During that time, I was doing that here in town at Christus Shumpert. And during that time I went to Centenary College. One of the professors that worked at Centenary actually came up to our facility and exercised regularly, so I got to talking to her, and she got me my first adjunct teaching position. So I started teaching adjunct there from 2002 to 2003. Still fell in love with it. Again, as a junior faculty, you kind of do whatever you have to do to get your experience, but it makes a big difference, and I'll come back to that point in a few minutes when I talk about the hiring committees that I've been on. So after that, I quit clinical exercise physiology, wanted to get my PhD and pursue research. So again, living in this area, I didn't have to move. I was given an opportunity to come here. So in 2004, I started a graduate program in the Department of Physiology. I joined Dr. Harris's lab in 2005. As grad students, we're given an opportunity. Are any of you, or have any of you gone through the graduate program here at LSU? Do y'all get a teaching opportunity to?
It's micro.
Okay. So our department, our department was very good about the 3 disciplines that you have to get for tenure, really: your research, your scholarship, and your service. So they were very good about giving us opportunities for teaching as well as the research. So every summer we had an opportunity to teach to allied health students. It wasn't very much, but it still got our foot in the door. So I taught them cellular and muscle physiology to the allied health students every summer, from 2005 to 2008. And that was a great experience. So I knew at that point, I no longer was just overly interested in doing research for my entire career, where I wanted to be in the lab 24/7. I knew I wanted to have a pretty large portion of my career being in education. I didn't know how it turned out. It's still unfolding as we're actually going along now. But I did know I wanted to go into it, and I wanted to make sure it was clinically relevant education. I wanted it to be either allied health, nursing, PT, OT. I always wanted to do medical education, but as some of you may be finding out, it's very difficult to get into medical education unless you're hardcore research. That is changing to some degree now, and so I was given a great opportunity that I'll get to in just a minute. So after I left here, I actually did a 1-year postdoc in Dr. Harris's lab. So I graduated in 2009, stayed on until July of 2010. And in 2010, I had to make a major decision. Do I stay in research, or do I really kind of make the big jump and go towards more education? At that time, I applied to about 10 or 12 different places, and I got one call back. It was from University of South Carolina Upstate, which is kind of a commuter campus, very similar to what you would find here at LSUS, extremely similar. The background of that school, it started as a nursing school, and has grown. It's probably almost 6,000 students now. But it started in the 60s as a nursing school. So I was in charge of the clinical, or the lab for anatomy and for physiology for the undergraduate nursing program. And I stayed there for about 10 months. Probably 3 months or 4 months after I started at USC Upstate, I saw a news article that came out and said that they're going to be opening a medical school in Greenville, which was 30 minutes in the opposite direction of where I was driving to go to work every day. So University of South Carolina opened a medical school. We started our first class last year, July 30th, 2012, and we're undergoing the LCME accreditation process now. So we've already gotten our preliminary accreditation, and when our first class graduates, we'll have our full accreditation, hopefully, if everything goes well. But so I was given a very unique opportunity that most people don't get. I was actually the very first faculty member hired at USC School of Medicine in Greenville, except for the dean and the associate deans. I was there by myself for a month going, okay, what do I do? And so I was, any committee service, I was it. So it was a very short meeting. We got a lot accomplished, but that's okay. So that gives you my background. One other thing at the School of Medicine, they were looking for educators. They don't have a lot of research space. They do have some, no animal facilities. So I knew going into it, I wasn't going to be able to have animal research. I knew going into it, if I did anything, it was probably going to have to be clinically relevant and working with clinicians. And I'll come back to that point in a little bit. So, but it's been a great opportunity. And one other thing that most junior faculty don't get. So first of all, the USC Upstate position was a tenure track assistant professor position. USC School of Medicine, I'm actually on a non-tenure track at this point, because in order to be on a tenure track, you have to have unit criteria. We're writing those right now. And that's actually a very interesting process. So I'm fighting for us junior faculty that are not going through the research side in a more traditional campus. So we're part of USC in Columbia, which is kind of like LSU Shreveport would be part of the LSU main system. All of our promotion and tenure has to go through USC Provost in Columbia. They're a very traditional school. They already have an established medical school that's very traditional. And so now we're having to say, look, we're going to do things different. We're going to reward teaching more so than research. How do you do that? And that's one thing that we're struggling with. And I'll come back to those points in a few minutes. So this is our school, just to give you a quick history. This building was built in 2007, and basically it was sitting there for 5 years. It was going to be a major research facility, and then the economy bottomed out. Funding rates went way down. So they said, okay, we're going to let it sit here. And then a couple of physicians, 2 vascular surgeons that are very ambitious, got together and they said, okay, why don't we start medical school? Why don't we emphasize teaching? And that's what they did. And one is now the dean, and one is the senior associate dean. Doctors Dean Yuki and Dr. Spence Taylor. They were really the ones sitting around the table in the room and put all their division down, all the guiding principles. And if you go to our website, you can see that. So I've included a YouTube video that I'm not going to show you. It's about a 5-minute video, but it shows you the teaching facilities that we have there. We have a lot of small rooms. We have conference rooms. They want us to think outside the box when it comes to education. They didn't hire us to just stand and give lectures. So that's what, that's actually what was very exciting about it, because I hate giving lectures, and that's why I'm doing mine. So this is, so why did I choose teaching? Well, as I told you, I had my first experience a long time ago, and I thoroughly enjoyed it. But what I realized is I don't like hearing myself talk all the time. I really enjoyed the students learning. And so this is an opportunity, again, in medical education that's rare, but it came along for me and I took advantage of it. But this is one of our rooms. It's called a multidisciplinary lab. And what you see here is we have 10 monitors all over the room, and we can use this lab. We use it for virtual histology. We use it for virtual physiology labs. But we also use it for small group work. So that's me in the background. I have had a haircut since then, but I went 14 months without a haircut because, well, I was busy. And this is myself. This is Dr. Dayrup. She's an MD, PhD, and she helped co-write this particular section that we're doing. In the front here, this gentleman with the beard, he is not a medical student. He is our Associate Dean for Student Affairs, Dr. Jim Buggy. And so one thing that I liked is the collaborative work between MDs and PhDs and clinicians. Okay. And I make that distinction because a lot of MDs are also not really practicing clinicians, so I make sure I have a clinician in the room as well. But this is a lecture that I did on membrane potential, which all of you know is very exciting for about one person out of 1,000. So we put this together. They're doing small group work. This has started off as a virtual lab for the first hour. The second hour, we're really going through cases. I have a couple of cases on hyper and hypokalemia, and we really emphasize what's going on with the ion transporter during that time. So the students work through the case. They're asked basic science questions. I'm not asking them clinical questions. So I give them a clinical case, but then I want them to understand the basic science behind that. So that's what we're doing. So that's a lot of fun. The other reason I didn't put on here because I didn't want any documentation, but let's face it, funding rates are very low right now, right? So one of the other things is if you're just doing this to get out of trying to get funding, that's a challenge because it's difficult to really work on these types of scenarios and get into the teaching process if you're not motivated and enjoy it. You can still do it, but it helps whenever you're spending a lot of time. These cases take a long time to develop, much longer than a PowerPoint takes to develop. It's very easy to throw together a PowerPoint from a textbook. You're not an expert in it. Putting this together isn't hard, but what's hard is the questions that you get. This leaves you very vulnerable as a teacher. People are going to say, all right, I have a question on this, and you have to be able to say, here's the answer, or you have to be even more comfortable to say, you know what, I don't know the answer to that. Does Dr. Bayrock know the answer to that? She may or may not know it, I don't know. Or you say, look, we don't know the answer, but tomorrow we'll discuss it again. We'll go look it up. And you have to be very comfortable with it. The other disadvantage is students in undergraduate, and I know we've got a couple in here, that go through this, they're trained to take tests and to sit through lectures, right? How often do you have them really critically think about what's going on? Not too often. And so when students are doing this, and it's the volume of information that a medical student is going through, not necessarily how challenging it is. As a graduate student, you really get more detail into the mechanisms, but as a medical student, you get a huge volume of information in a very short time, and you have to go and process that and take a test on it. So that's challenging, so we asked them to read. So for this, they had to read about 3 hours before they showed up to class. Otherwise, they wouldn't have gotten anything out of it. So when they get to class, they have to have a good understanding of what I'm going to talk on. So I give them a reading assignment from a textbook, and then I move forward from that. So some challenges for faculty entering education or medical education. I've got several challenges, and then I'm going to give you, hopefully, some solutions to that. First one is getting your foot in the door, gaining some teaching experience. By the way, please stop me if you have any questions at any time. I want this to be very relaxed and to get to what you guys are struggling with, not just me telling you what's going on. Learning how to be an educator, maintaining basic science research, new research techniques, understanding the clinical world, and finally understanding and navigating tenure and promotion. So the first one is getting your foot in the door. This one, it sounds easy, but it's actually very challenging if you're not given opportunities. It really depends on where you're at and what your institution, the philosophy of your institution is when you go through your training process. But some of you I know are going into departments right now that really don't care about education or don't give you the opportunities for education. So how do you do that? First of all, you attend medical education conferences. You've got to find out where they're at. One of the big ones that I believe it's the first week of November every year is the AAMC conference, Association of American Medical Colleges. You're going to have educators there. They're all talking about this. It's the LCME documentation, the accreditation process. LCME is forcing medical schools, even traditional ones like Harvard, Princeton, all of them to begin changing how they deliver medical education, or how they deliver their lectures. They're no longer wanting you to sit in class all day long and just hear me talk about it because I'm an expert. So they're asking that a percentage of your class be non-didactic lecture, or what they call active learning. So there's innovative learning and active learning. So they're wanting more active learning to take place. Okay, so also the American Physiological Society is having a really nice conference. I believe this is in Bar Harbor, Maine, if I remember right. And it's in June of 2014, and I know I've already begun to receive information about this. So if you're a member of the American Physiological Society, you should have already been receiving some type of information. If you're not, go to their website. and you'll be able to pull this conference up. But it's going to be a big one. I hope I can get away to go to that one. In fact, hopefully we'll be able to drive up and take a family vacation up there as well. Others, connections at meetings. You have to start going to meetings that are medical education or that are both scientific and education. So I know some of them, like ED, will have some education portions to their meeting. Start attending those, get to know those. The medical education field is actually quite small. When you really start to meet individuals, our Associate Dean for Medical Education is one of the big individuals within this conference, and so she knows everybody. So if you say a name, she pretty much can say, yes, I work with that person here, I work with that person over there. And so it really gives opportunities for networking, and you have to take full advantage of those networks, because you never know what's going to come up. But if this is something that you're passionate about, you have to be able to make those connections and keep them. So, journal articles. Start reading medical education articles. There's about 4 or 5 journals that I read on occasion, and find out who's publishing and what they're publishing. Are they studying the techniques of learning of individuals? Are they writing about what's going on at their institution? UC Davis, University of California, Davis, has published some nice information about some of the changes they're making to their medical education on promotion and tenure within the last 2 to 3 years. So you've got to just get in the literature, just like you would for any of your background. You have to be able to look at it and go, okay, who are the people that are publishing, and how do I get to meet them? Just email them. Most educators are going to be very happy to share their experience. So gaining teaching experience, how do you do that? Well, if you're given opportunities, like the Allied Health School, great. But if you're not, then you have to let it be known to those that are in charge, the course director. So you find out who the course director is for whatever you might want to teach, and you tell them, I'm so-and-so, and I really want to do some teaching. Is there opportunity? Even if it's not in your department, they may allow you to do that. Oftentimes, they're short on individuals, and so sometimes just knowing an extra person's available, absolutely you can do it. Even if it's just one lecture. You know, you might be a microbiologist, but that doesn't mean you can't teach in a physiology course. You can teach the cell biology portion of it or something. So there's ways to get involved. Medicine is becoming more and more integrated, in case you haven't figured that out. We're no longer just physiology. We're no longer just pharmacology or just anatomy. You've got to start pulling all these together. And when you're teaching, you have to pull those together as well. So try to get your name out there. Local undergraduate universities. Like I said, I had a great opportunity. I met a professor that was at Centenary. She gave me my first big break as far as getting in. Go to these schools. Introduce yourself. We have a person that teaches at LSUS that went through this graduate program in physiology. Whenever I found out I was going to be going to USC Upstate, I went to her classroom and I sat in on her classroom. How did you teach undergraduate anatomy, being a physiologist? So I went, for about 2 weeks, I sat in on her lectures. Dr. LeGrand at LSUS, and you know her. She's fantastic. But she had experience at a medical school. She went to UT, I believe it was UT Health Sciences Center in San Antonio for about 8 years. She was chair of the Department of I think it was, well, I don't remember which department it was, but her research background was respiratory physiology. So when she came back here, I found out about it and I took full advantage of going to see her. Online courses, yeah.
Undergraduate institutions, are those only four-year colleges or community colleges also count?
Community colleges also count. In fact, I'll go ahead and tell you about it. So from 2011 to 2012, again, being one of the first faculty members at the USC School of Medicine, I was able to be on the hiring committee for that year. So we looked at a whole bunch, and the first thing that we're looking for was education experience. By the time you get your PhD, we assume that you have good knowledge. Publications are important, scholarship is important, and that was always looked at. But the first thing they're looking for is what is your teaching experience. It doesn't really matter. Obviously, medical school teaching experience is best. But if you're a junior faculty, it's understood that you're not going to be able to teach medical school as a person just graduated. But if you've had other opportunities, whether it's online courses, whether it's undergraduate, BIPSI, places like BIPSI, two-year colleges, doesn't matter. Any experience in an education setting where you're facilitating learning, that's what we're looking for. The more appropriate it is to what we're doing, obviously the better, but it can be any type of teaching experience. So don't say, well, this online course that I'm helping teach isn't going to help. Actually, that's going to be very helpful because that's the way of the future, technology. So take full advantage of any opportunities you get out there. Don't be afraid of instructor positions. So again, getting your foot in the door may mean that you have to take an instructor position for a while. Those oftentimes open up within a couple of years to a full associate or assistant level position. Exam course instructor. You may have, some of you may have taken like a Kaplan course on to take the GRE, MCAT, or anything like that. Those courses also count for teaching experience when you're looking, especially for a junior faculty member just coming out of either a graduate program or a postdoc. So one of our other new junior faculty, she came from University of Florida, so she was an instructor for a few years, and that's how she got her foot in the door. So she knew very well she wanted to go into medical education. So she got a PhD, she did do a postdoc, she took an instructor position for about 4 years, and now it's with us. So all of that experience is going to help, but you kind of have to make decisions. What do I want to do with my career? And once you've made that decision, don't look back, take it full steam ahead. So learning how to be an educator, very important. You want to be an educator, but you're in basic science. How do you learn to teach, right? Some places are better. Some places teach you how to give really nice lectures, the old-fashioned way where you stand up with your PowerPoint, you make everything move on your screen, and that's supposed to be active learning. That's not active learning. It means you're a great facilitator. It means you're a great teacher, and you can tell stories, but it doesn't actually mean the students are learning anything. So how do you figure out how to be an educator? Trial and error is really what I found works the best. And believe me, if you're not teaching well, the students will tell you. So one of the things that I do is I go and I look at what everybody else is doing. This is an opportunity I had. So this gentleman is Dr. Emery. He is a cardiologist at USC School of Medicine and GHS. GHS is Greenville Health System, which is where the USC School of Medicine is embedded. It's kind of like if you were to put a medical school, if you had just built a hospital here and then start medical school on it 100 years later, that's what we did. So, but this is Dr. Emery. And so what you see here is a gentleman. This is a standardized patient. Any of you seen the Seinfeld episode where, they talk about all the different diseases they get, and Kramer ends up getting gonorrhea and plays it very well. We have standardized patients, and we pay them. And people get paid very nicely to do this. This gentleman came in, and he's hooked up to electrodes, and this is his EKG. And so the students are looking and learning about EKGs off from a standardized patient at the same time, taught by a cardiologist. But this is a basic science class on normal physiology. So one of the things that I had an opportunity to do is I was academic year 1 director for the medical school for the first year. One of the responsibilities I had for that was to go to a lot of classes to ensure continuity across the curriculum, as well as to make sure we're not overemphasizing something and basically reteaching it 2 or 3 times. That's one of the things that we're wasting a lot of time on teaching. Anatomy will teach something, then physiology will come back and teach the same thing, and then pharmacology will teach the same thing. We're trying to eliminate all that by integrating. And one way to do that is have someone attend a whole bunch of classes. So I got to sit in and see a whole bunch of different techniques being used. So I took a look around. This is one technique. Here are 2 other techniques. So this is medical school, believe it or not. So they're outside. They're learning about VO2 max. So they're actually doing a VO2 max test. One of the things about our institution is we have our students. We're embedding exercise as medicine into our curriculum. So we're not only teaching exercise as preventive, but also as therapy. So they're learning about VO2 max. Here on the right-hand side, they're playing a board game on osteoporosis and calcium regulation. Yeah, pretty cool, isn't it? What did you do in med school that board game? So, thinking outside the box. How are you getting students learning? They had a reading requirement. They come in there. And why am I going to reteach their reading assignment? So we've got to get them more actively engaged.
Making those board games yourself, or?
This was done by Dr. Trill. Both of these lectures were done by Dr. Trill, and yes, she's making board games from scratch. that takes a long time, believe it or not. So she also used crossword puzzles. So as a study technique for micturition, she had them do a crossword puzzle. So, so there are different things that you can do. I use more clinically, a lot of my lectures are clinical cases with student interaction. So I have them come in with a case, they go through it and they ask questions, so they're working in groups of 5 or 6, and then I open up to questions. All right, question number 1, group 1, what did you guys get? All right, group 5, 6, group 7, did y'all find anything different? So it allows them to communicate. And I'm really just there to facilitate. I'm there kind of leading the discussion, but I'm not really imparting on any knowledge. Now, when something is said incorrectly, then I correct it. But more or less, I'm trying to have them have the discussion themselves.
My cell biology teacher in undergrad had this, initially it was annoying, but he just loved to sing. And so like every class was like karaoke. And then a lot of our assignments ended up being that we ended up having to write songs based on mechanisms and pathways and stuff. So, and like you said, it's a lot of work just getting ready for that. So he would actually have lectures that were, a lot of songs. And then when he asked us to do it, I was like, oh my God, like this is difficult because not only are you trying to take the information and use it, but then you're trying to make it rhyme or something.
That's right.
It's just, it was miserable.
Yeah.
But I mean, it's stuck though.
And you can actually do songs for different diseases. Mm-hmm. So those are all over the place. So that, it's pretty interesting what's out there if you really start spending some time on the internet. Our Associate Dean for Education, she wrote a play for renal physiology. And so it's an entire play on renal physiology, and she had the students act it out at her previous medical school. So, it's, it takes time, but it is actually very, I think the students are liking it. But initially what you find is a lot of pushback from the students, but once they start figuring out, you know what, I'm asked to be here. Medical education is very interesting because it's the only graduate or the only professional program that really is doing things old school. Most other programs are the Socratic method. You go in and you learn about it. Law school. All of these other programs, even graduate school, you're really not sitting through lectures over and over and over. Now you have some, but the majority of your learning takes place independently and through your own facilitation and discussions with others. Medical school, for whatever reason, hasn't jumped on board with that yet, but that tide is changing. And so it's nice to see it changing, but it takes a little time. So make sure you see other people give lectures or facilitate instruction, because I think you'll learn a lot by sitting in on as many different individuals as possible.
I think it's quite obvious. However, the obvious sort of slight issue with it is that if they're given a 3-hour reading assignment, then that doesn't remove the need for, even though they're taking it in themselves, that's still the in a sense anyway. So they've still got to take it in and absorb it and be able to regurgitate it in whatever format you've given them. You're helping reinforce it, but it's not removing the need to learn everything in a 75 road anyway in the first place.
That's right, and that's a great point. I'm glad you mentioned that. So one thing that you have to do as an educator, you have to be very aware of the amount of time the students are spending in preparation. So you don't give them a detailed reading assignment with a whole bunch of details that they're not going to memorize, right? You give them a reading assignment that they can get through and understand the basic concepts. Again, it has to be toward the audience. So if you're looking at medical education, you're not going to go through an entire pathway in cell biology for a 1-hour class, right? You really want them to get a big picture. So we actually use a little bit more clinically relevant textbook without the mechanisms. And that really cuts down on the reading time. They come to class prepared, and then in class you can reinforce some of those mechanisms, because you're right, they have to then go out of class and remember this kind of, remember they have to study that night or over the weekend on what you talked about during the week. So it really forces you as the person in charge and putting together these presentations to come up with ways to cut down on the reading assignment and to get at what is necessary, and not worry about just telling them everything you know about your particular area. You have to eliminate that train of thought. And that's what we've been doing in medical education for years, is just telling, yeah, I'm the scientist who researches this, so I'm going to go in and I'm going to tell them everything I know about this. we're moving away from that. And it's really cutting down on the prep time, making it clinically relevant, and then some of the information that I have in a few slides will help that as well. If you go back to, if you are aware of how people learn, then you can really maximize their ability to retrieve the information. And so I'll talk about that in just a few slides as well.
So I'm not a medical student, but I ride the shuttle bus with them, and they're always saying, you know, oh, well, I skipped this class, I slept in, but it's okay because my note taker is going to handle it for me or something like that. And I know that a lot of them don't even go to the lectures. Do you find that you've reduced that using this technique and that you're getting more students in the classroom?
We only have 1 year at our school, but
Okay.
yeah, that is the general thought process. This past year we had about 95% attendance on a given day,
Okay.
Which is much higher. Some of the biochemists, the older biochemists that we've hired since the school is open, you know, they would say, well, I had 2 people in my class out of 100.
Yeah.
So 2% of individuals showed up for that lecture, so they must have been biochemistry undergrads who really loved it. Or the gunners, everybody calls the gunners. These are the ones that really want to be the top person in the class, right? So there's a couple ways to get around that. One, when I'm doing these types of classes where student interaction, there's no note taker. So if you want to get information on that material, then you have to be there. But we all know everybody learns differently. So some people are going to learn better from just reading a textbook or looking at a PowerPoint. Some of those individuals will skip class, but the majority are not skipping class.
And do you guys podcast your lectures?
Right, so anything that we give a traditional lecture on, because we still do give traditional lectures, those are all videotaped and put on iTunes U, I believe. So we do have that. It is up to the faculty member if they do a podcast. What a lot of people are doing are these, I don't use them, but they're called self-learning modules. And it's basically like a podcast. It's a different program than PowerPoint, and it works through the student. So it might be an introductory slide, and then it gives them a couple of questions. They answer the questions. So it's almost like a reading assignment, only through a PowerPoint, or they call it. I think the program they use is Articulate. Is the one that they're using for these self-learning modules. I personally don't use them. I find with physiology, I want you to read. I feel like you need to be able to read material and have discussion based on your reading, because that's what you're going to do as a physician. As a physician, you're not going to be given an SLM on an article, right? So if you want to go learn something new, you need to go to the literature and read it. So the more comfortable you are with reading that material and picking out the important information, that's the approach that I'm taking. But there are some disciplines that don't require that as much. And so an SLM is great for those types of disciplines. I just feel like with physiology, what I teach, an SLM isn't exactly to the level that I would like to see it. I want them to get into the literature, read the details that are in the text or that are in the article that I'm having them read before class. But those are 2 great points. How do you get them to show up? And you're absolutely right. There are certain lectures, if they know that it's going to be a lecture, we will have decreased attendance. But if they know it's going to be group work or clinically relevant work, we have case studies that we do weekly as well. The attendance on those is extremely high. We do have a mandatory attendance, but that doesn't mean they don't show up, because we don't take attendance. So even if they don't show up, they're not getting docked anything. So there's no repercussion for them not to show up. What we do is we try to say, look, you're going to be a professional. We want them to be professionals from day one. So they're actually treating this as a professional, as a job, more or less. They're not showing up in flip-flops. When they come to class, they're dressed in nice button-down shirts. The ladies are dressed appropriately. We want them to be respecting this position from day one, not from day one of residency. So there's a much different train of thought, even within our institution. But you do find that, and a lot of schools don't really know how to answer that. But I do find that if you make it engaging and you make it clinically relevant, students are motivated to be there. So once you looked at other people, you got to find out what it is you enjoy. I might go and say, you know, that's a great lecture, but you know what? I don't want to do that. That's not what I'm comfortable with. If you're not comfortable in the classroom, the students are going to eat you alive, and they're going to know it. If you they're going to be asking questions you can't answer, and then they will just, they're like attack dogs. They're just going to be on you. So you have to be comfortable in the classroom. If you're comfortable giving clinical scenarios, use that. If you're comfortable giving other types, use that. But realistically, if you're most comfortable giving a lecture, you've got to get with that and then slowly try to use other techniques. Start with what you're very comfortable with and then make changes. If you try to do it all at one time, it will be very difficult for you and you'll get very frustrated. Okay, and then this is just as a reminder, you're there for the students learning. You're not there to be a great speaker. This is not your opportunity to be a comedian. This is not your opportunity to go out and set yourself apart as a great lecturer. Oh, he's a great lecturer. So what? The students learn what they needed to learn when they're a physician 10 years from now and they're treating you as the cardiologist. Who cares if you were a great lecturer, right? It's all about them. And so you have to think, you know what, be humble, forget about your expertise. The objective is the students learn as much as they can. And that's what you're trying to go for. And this is just a resource. This website has a lot of resources, but this is a great book, How Students Learn, and that will help you. So if you know how students are learning, then you can approach learning different. If you're not really caring how students are learning or how individuals learn, then what good does it do, right? So you need to make sure that you are understanding how people are learning. I'll give this to Mike, so if you don't want to write it down, I'll give you all this, and he can send it out to everyone. That way you have
The PowerPoint?
resources. The whole PowerPoint, absolutely. So, okay. So I just wanted to give you a little bit of statistics, and I won't go into the studies. You can read the studies, but going back to that whole idea of how students are learning. So this was a study that was released in 2011, and you see different types of methodologies here. You have study, repeated study, concept mapping, and retrieval practice. Study, in this particular article, just basically means students were given a textbook and said, here, read this, and then they took a test on it. Repeated study was, here, read this passage, here, read it again, and then take a test on it. Concept mapping, are you, any of you familiar with concept?
I read a little bit about concept.
Basically, you take a chapter, it's almost like you're outlining a chapter, but you're making bubbles with it instead. So you might have a main theme for that chapter and you put it in the center. So it might be congestive heart failure. Okay, I teach cardiovascular and cell physiology. That's my area of expertise for teaching. So we go into that, and so it might be congestive heart failure. From there, you talk about the arteries, you talk about the left ventricle, and you talk about pressures. And so I'm drawing arrows to different bubbles throughout. And so students can map it however they want to. It's individualized to each person, or you can have them work in groups. But that's concept mapping. It's very popular. So this was one of the reasons why this article chose to do that. And then retrieval practice is basically saying, okay, you're going to study something. We're going to ask you some questions about it. In this article, they just basically had them freehand answer. It was almost like the written exams, you know, at the end of your year one or whatever. Just basically tell me everything you can possibly tell me on the topic. And that's essentially what the retrieval practice is. And the more that you do that, the more that you recall the information and learn. So if you can quiz students, you're getting them to retrieve what they've already learned. So they read information, they took a test on it, and then they read it again. And you can see that the retrieval practice, how they did on their questions. This is just basically knowledge questions, and these are your higher order thinking. So if you go back to Bloom's taxonomy, I don't know if y'all are familiar with that or not, but the different levels of thinking from knowledge all the way up to analysis and synthesis. So the inference questions are going to be your higher order thinking questions. Okay. So you see that the students performed best whenever they were asked questions. So if you go in and you have discussions and have them retrieve the information that they're reading instead of just going through the reading process. Big difference. Now what you see on C is metacognitive predictions. Any of you familiar with metacognition? It's interesting. Basically all it is it's thinking about thinking. Okay? And so the students were asked, how do you think you're going to do with these different techniques? Do you think you're going to learn most by studying at one time? Do you think you're going to learn most by studying it a couple of different times? Do you think you're going to learn most by concept mapping? And the students thought they would learn the least by going through and answering questions on what they read. but in fact, that's the one method that worked the highest. Right? So metacognition, really thinking about thinking. That's what you want to key into there. I'm providing this to show you that there are different ways to get to students without just delivering a lecture of what they're supposed to be reading. That's not going to help them learn. There's evidence to show that. Another technique, deliberate practice. Essentially, it's very similar. The main difference is there's a physician, this Wyman, the third author on this paper, was a physicist at the University of Colorado, and now he's in Canada. But he came out with these different ways of learning, and he wanted to study. And so what you're seeing here is the test scores of individuals that are traditional lecture technique from very experienced lecturers, and a technique that was what they called deliberate practice, and I'll talk about that in just a second. But the deliberate practice was delivered by very inexperienced individuals. I don't know if those postdocs or graduate students, but it was inexperienced individuals. And basically they had to read some information, and then they were given scenarios to problem solve in groups. So again, could be very similar to the clinical scenario where you have a person coming into the emergency department who is weak or who has an unusual EKG, right? So students are going through the problem solving process together. So they've read information ahead of time, they come in and they're going through that. And you might remember something very pertinent, they might remember something very different. So you're going to talk about it, and their scores, as you can see, were much higher for this type. And so there's different, so if you look up deliberate practice, you'll see a couple of different methodologies under that. But again, it goes back to this whole idea of get away from your traditional lecture, try to figure out what's engaging the student, what's allowing them to really process and move to that higher level besides just regurgitating some basic information. So moving on, maintaining basic science research. So we're asked to be educators at these institutions, and that's one of the primary things at USC School of Medicine in Greenville. But at the same time, old school thinking, right? We've got to have some research in our back pocket. If I want to make promotion and tenure, most schools want scholarship. How you define scholarship is individual to each school. There's a saying that goes around our school: once you've seen one medical school, you've seen one medical school. So basically that means all of them are different. Undergraduate is very similar. Your P&T criteria are the driving factor for faculty, right? We want to know what's going to get us promoted, what's going to get us secure, and what's going to get us a little bit more money. Well, some schools are going to require you to maintain basic science research, but without startup packages, without facilities. How do you do this? So, one of the struggles that all of us, I shouldn't say struggle, one of the concerns that we all have at our institution is how do we continue our science research? One thing I do is I keep up my relationships, but you now have to start developing relationships with clinicians and start thinking, okay, what are other ways that I can do scholarship besides my traditional in the science lab injecting my animal? Okay. So you go to a physician, you say, what problems do you have that need to be solved? That's what you do. You let them be the driving factor, and then you figure out a way to solve it. That's your job as a scientist, right? You're putting all this information together. But if you don't know the clinical side, you're only guessing at what's going to make a difference. So you sit down with a clinician in an area that you're passionate about, and you say, okay, what do you see in your clinic that you wish you could figure out why this is occurring? When they all come in with this disease, why is that? And is there some literature that can help us get started with some type of research? That's where you should be starting if you're limited on space or you're limited on funding. Relationships. You need to keep up your relationships within your facility, but also in other universities. Nowadays, we're going to have a lot of collaborations, right? Everybody's wanting to collaborate. And so you want to be able to do that within the university, but also with other institutions. We'll talk about how this relates to P&T in just a few minutes. But you've got to get the clinicians involved, especially if you want to be any type of researcher in medicine, nursing, physical therapy. You need to get the guys that are on the front lines treating the patients involved in that research and figuring out how to solve these problems. That's how you're going to really become successful with basic science research. Direct your, even if you do have some lab space and doing cell culture, you have to make sure you're answering questions that are going to be relevant to those individuals. And if you can do that with clinical work, even better. Again, main point, you have to continue to collaborate. The other thing is, you may not be required to continue to do basic science research. Some institutions may not require it at all. That's a good thing if that's okay with you. But remember, the longer you're out of basic science research, the more difficult if you ever want to get back into it. So once you make that decision, I don't want to do any clinical or basic science research anymore, 5 years down the road, if you ever want to get back into it, it'll be very hard. So make sure you're making that decision and you're aware of that decision. And that may be just fine with you. That may be exactly what you want. But just realize 5 years, if you go to a more traditional institution and try to get in there, it's going to be very challenging unless you have a way to get collaborations going where you've kept up that collaborations, even if it's just a little bit, until you're ready to make that cut the umbilical cord, if you will, make that clean sweep into medical education or any type of education. Always try to keep some science in there. So research techniques, I'm not going to read these off to you, just very quickly. The new research techniques that you might be learning, education research. There's a ton that still needs to be answered. In the old days, a lot of this research really was just anecdotal, just someone's opinion or what are we doing. And now we're getting into scientific methods. And if that's something interesting to you, go for it. But you need to read up about it and find out exactly what it is. Comparative effectiveness research. This is another type of research, especially in the hospital setting. You can figure out what's working. So a surgeon comes to you and says, I've been trying this technique for a couple of years and we want to see if this is better than the old way that I learned on. Okay, so these are different therapies that you can be looking at. Again, getting the clinician involved is going to be very helpful for your success in the future. Translational research. You don't have to have a lot of science, basic science base. Your hospital can be your science lab. You just have to know how to navigate it. Find someone who's done this type of research and let them be your mentor. But you need to be able to find that and move forward. So, understanding the clinical world. So how do you get a basic scientist in the clinical world without, most of the time clinicians and PhDs, they go head to head, right? Oh, well, you guys don't understand anything we're doing. You guys are working with animals all the time. And they don't understand what we're doing. They don't really care about the mechanisms. They just want to make sure their patients are healthy. So how do you get those two together? You have to reach across the aisle, kind of like politicians, right? You got to reach out. So one thing that you can do is get yourself embedded into a clinical department. This is some interesting statistics that I found. Between 1981 and 99, basic science faculty in clinical departments increased 115% versus 41% in basic science departments. So that means a lot of PhDs are now embedding themselves in the clinical side, and that's actually a good thing. So the more that we can start developing and breaking down this barrier between the clinicians and PhDs, the more collaborative the research, and the more we can move forward with treating medicine. Embed yourself in a clinical department. Even if you're in a basic science department like I am, I attend rounds. I go on rounds with physicians. I develop my teaching materials with clinicians. And I have clinicians co-teach my classes. This is how you're going to learn what they're going through every day. This is how you're going to learn what they do on a day-to-day basis. So don't be afraid to ask a clinician, can I go on rounds with you? It's pretty cool, and you see what they're doing. And you realize a lot of what they're doing really doesn't mean a whole lot to what you're doing in the lab. So if you can tweak what you're doing in the lab now to meet what they're doing in the clinic, the better off you're going to be. So don't be afraid. You're going to find some clinicians that don't want to have anything to do with PhDs. That's okay. You go until you find one. If you need help, what you do is you get your chair. You go to their chair and say, look, I want to be in the cardiology department. I want to follow some cardiologists. So you get your chair and he goes to the chair of cardiology and say, all right, I've got 2 PhDs that want to follow clinicians here. Do you have any that are interested? The ones that are interested, they'll come out and you'll follow them. The ones that are not, they'll stay aside. But it really helps, makes a big difference when trying to work with collaborations for research, as well as just learning how to teach a clinically relevant. Because we're not taught how any of this clinical relevance a lot of times. Okay. Read clinical textbooks. One of the best ones I've found is a pathology book, Robbins. I think it's Robbins and Cotran. It's a really good one. And there's another one, and I forget the name of it off the top of my head, but it's more of a physiological based. Robbins is more of a pathological based textbook. But read your clinical textbook. Start asking yourself questions. And then finally, try to find meetings that are both clinical and basic science, not just basic science. This is just a nice statistic recently. So right now in clinical departments, 58 basic science PhDs, in clinical departments, 58% of PhDs that you see in this area are now in clinical departments versus 42. 20 years ago, those numbers were reversed. 58% were in basic science departments, 42% were in clinical departments. So you see, as appointments are becoming more available in clinical departments, there's an integration of the two. Don't be afraid of it. Actually embrace it. It's very helpful if you want to go into education. The more that you can make relevant what you're teaching, the more students are going to be involved. Because right now, all they recognize is when an MD comes in to speak on a topic, you get almost 100%. When a PhD shows up, it drops, especially if it's more of a traditional lecture. So the clinical relevance, I showed this. This is a couple of our students, or 3 of our students. We have a simulation center. First year, they're already going through a very rigorous simulation on a weekly basis. Not only that, we're the only medical school in the country that requires our students to become emergency medical technicians. And they actually practice as technicians while they're going through medical school. So they go out into the community as technicians, and they're seeing where their patients are going to be coming from, and they're seeing where their patients are going to be going home to, which is hugely important for trying to understand how you're going to treat somebody. If you give a drug and they don't know where they're going home, and they can't either afford the drug, or they don't have access to therapy because it's a 45-minute drive from here to there to go to physical therapy, you have to now figure out other ways to treat patients. So having them in the community, you also see the excess and waste within the 911 system. If you don't talk to our first-year students that have just finished, a lot of them didn't even go on a relevant run. Some of them, first run, a 2-month-old baby died on the first run of one of the students. Okay? But some of them have been doing monthly EMT runs without ever going on a real serious run, because people are calling 911 saying, I need you to come give me my medicine. And so they go to the house and they give them medicine. Okay? So we're trying different ways to cut down on this waste of the EMT system. So again, making everything clinically relevant. That's what's needed. So, and finally, the point of understanding and navigating tenure and promotion. This is the big one. This is what really you should be looking at when you go out and try to find a job. You need to look at the fine details. Again, every school is going to be very different, but you need to be on their website and you need to figure out, what does it tell me in paper that I need to do, and then what is the unwritten rule at the school. So if you talk to somebody, my promotion and tenure for the assistant professor job that I took, it doesn't say how many publications do you need, what do you need to do. But I talked to all the junior faculty and I said, okay, what is the reality here? What are my expectations for when I go up? What is Columbia going to look at for me in promotion and tenure? That's what you need to be doing. So when you go for job interviews, not only do you look at what's on paper, but you need to be very diligent in talking to each of the junior faculty to find out the expectations that they are being told that are not written down, because there's a lot of unwritten rules about it. So what tracks are available? You can see that there's a ton of different tracks. Okay, so there's investigator track, there's research track, clinician educator, clinical track, educator track. All of these are available to you. So the educator track is very low. That's one of the problems. 34. So in 2011, this article came out. I think at this time there were 129 medical schools that they sent out surveys to. 98 responded. Of the 98, 34 of the 98 medical schools had an educator track. You can see the majority did not have an educator track. So how are you going to be successful if you want to be a medical educator? You take a job at a school that doesn't have an educator track. Even the school I'm at right now doesn't have an educator track. So how do you be successful in promotion and tenure? So you have to look at all the details. So medical schools, tenure track, 70, this is again the same article. 79 out of 98 had clearly defined tracks, 3.5 tracks per medical school, 172 research tracks within those schools. 91 of them were tenure eligible. 113 education tracks, approximately 40% were tenure eligible. That's a lot of tracks for just being 34 schools. 39 clinical tracks. So, tenure using traditional criteria in a changing environment. This is something that's very important. So we're writing our P&T criteria right now. And we're finding that it's very difficult because the traditional medical school in Columbia wants you to be able to say, well, you got to have this many publications, you got to do all this type of research, but yet we're being hired to be educators. That's a lot different. So when you're going through this, you have to look, how different do the P&T criteria look based on the expectation of your job? Is your job 60% teaching versus 30% research versus 10% 10% committee work, or is it 40, 40, 20? What are those balances? And your chair should be able to fight for you. So if you go in and you're 60% research, but yet your P&T, or sorry, 60% teaching, but yet your P&T is all research, then you need to be asking some very straightforward questions. How am I going to be critiqued? What expectation do you have for scholarship, even though you're telling me I only have 30% for scholarship to do? Does that mean it decreases the number of publications I might have? So some schools will say, okay, if you're 50% research, here's the number of publications you have to have. If that decreases to say 20%, then they'll take a fraction of those publications. Some schools won't. They'll just say, you know what, you need 10 no matter what, even if you're 20%. And you need to be asking those very blunt questions to your chair and to the junior faculty when you go in. That's very important. Team-based instruction, so that just goes to the point that everybody wants team-based instruction, they want collaboration, but yet your P&T criteria are really written for individual investigators. Some schools are doing better. Again, UC Davis is publishing what they're doing for transitioning for their P&T. Not all schools are ahead of the game. Most of them are not, so you have to be aware of which ones are more innovative in that respect. Choosing a non-tenure track. I put this on here because there's a lot of individuals that are not on tenure track, and it's okay. But you need to find out, is it a good place for you? Does it work? Some people want the security of a tenure track, but it's also more stress. You have a lot more hoops to jump through, if you will. It's kind of like graduate school. You got to do everything just right. Non-tenure track might be all right, especially if you have a spouse that wants to move a lot. You know, a non-tenure track is actually a good way to move, to make sure you're flexible, but also not worry about some of this stuff. The nice thing about the non-tenure track is oftentimes you can negotiate a higher salary with the non-tenure track because they understand you're taking a little bit more risk.
How long are those positions usually held for? Is that like a 5-year gig?
That's a great question. So sometimes they're 1 year first. So a lot of times you might see a visiting professorship, and that could be a 1 year. If you do well, then it turns into a 3-year rolling contract, and then after that, they turn into 5-year rolling contracts. So it just depends on the institution. Some of them you'll walk in and they're automatically 3-year rolling contracts, no matter what, it's 3 years. Some of them, they kind of grade it. First year's a trial year, you don't do good, then they give you 3 and then 5. All of that is very dependent on each individual school, so that you need to ask those questions. That's a great question.
I just have a short comment on that. I attended the lecture of the lady who started as a visiting professor for a year, not in the med school, in the college, and it turned out to be 3 years. And she performed well, and they got her on the tenure track in the end.
Yeah.
But
you're absolutely right, and oftentimes these can turn into tenure track if you want them to. So it may be another interesting thing, and it's kind of like what we at USC School of Medicine in Greenville are doing. I have the opportunity to go on tenure track when it's available, but I also have the opportunity to stay on non-tenure track and start the tenure track when I want to. So let's say that it takes 2 years off the fellowship. I can take time to develop my teaching, and then when I'm ready, start on my tenure track, knowing, okay, when my clock starts, that's when my publications and all of that start. So I can take some time, really focus on what I need to focus on, and then get back to the research and start that. Some schools allow you to do that. So it really just depends on each individual school and what your individual goals are. If you want to become a great educator, it's not a bad idea to look at a non-tenure track initially and get on a tenure track when you're more comfortable and when your teaching is set. When your teaching is set, you can make adjustments, but when you're first setting it, it takes a long time to develop these active learning methods, a long time. And if you don't feel like you can do that and all the scholarship required, this may be a great option for you initially. But just make sure that you build into your contract an opportunity when you're ready to go on a tenure track.
Yes, that is.
And so again, just some more statistics. I'm not going to go through those. I'll let you read those. This again is even more statistics just on how many people are on a tenure track versus a non-tenure track. I'll let you look at those. I know we're getting short on time here. This one is for medical schools, and I want to point out a difference between this slide and the one I'm about to show. What you'll see here is on a non-tenure track, 57 and 59% of faculty. This includes clinical faculty. So that seems like a lot right now, but this is clinical faculty. Here is the difference for basic science PhDs. So roughly 28% of basic science PhDs are on a non-tenure track. So don't be afraid of them, but really understand what you're getting into and what your ultimate goal is. It's okay to be delayed in your tenure track, because if you jump on a tenure track right away and you want to really focus on education and teaching for a while, you may not be successful when it comes time to go up for promotion and tenure. So set yourself up for success, but also make sure your chair is willing to set you up for success as well. Some of them are more traditional, let's just cut to the chase. Some of them, they're really willing to work with you, and so you have to, again, talk to each school individually. And then here's some reasons why there's an increase in non-tenure track faculty. And these reasons were published from the standpoint of the dean. So if you look at the dean's reasons, you can see what they are. But there's also articles out there that are more anecdotal. I think the website is Chronicle of Higher Education. There's some articles where they interview people that chose not to go on a tenure track. And you see the perspective is much different. They chose it because it allows more flexibility. They can negotiate a higher salary. They don't want the stresses of the tenure track. So from the dean's perspective and from the faculty member's perspective, it's much different. So just keep that in mind. It's not the worst thing in the world. So success on tenure track, find out what you're passionate about. Know your requirements before you accept a position. Know what counts for each domain. Teaching, scholarship, and service at each institution. It's going to vary greatly. It's going to vary. Some undergraduate schools that are just four-year schools, no graduate programs, they want you doing 50% service because they're limited on faculty. So you're doing a lot of service and teaching. They really don't care about scholarship. If you want higher education, the medical schools, you're going to have some type of scholarship no matter how you define it. Publications, peer-reviewed publications is what it's going to boil down to. And so can you define that within basic science lab, or can you do that with your translational or educational research? Those are questions you need to ask. And then keep documentation for accomplishments. Don't wait until year 5 when you go up to PMT to you go, okay, what was that I did back in the first year? Just get you a file and start keeping it from day 1. Makes it much easier. So, differences in undergraduate and medical education, your startup package. I'll give you an idea. My startup package at USC Upstate was $25,000. Okay. I didn't have to do a lot. It was mostly teaching. The main thing, I had to have just a few publications. It didn't matter where I got them. My contract was a 9-month contract. So my summer times, I could do whatever I wanted. Most of the time on a 9-month contract, you can do either additional teaching for more money, or you can go off and do research, whether it's there at that institution or at another place. I had the opportunity to come back here. I could have worked all summer. I had family here in town, so I could have stayed with them, worked all summer, got a bunch of publications, and really knocked out a lot of my scholarship. But you have to be, if you understand this part of it, then you can figure out, okay, how can I be flexible? Clemson University is very close. USC Columbia is very close to where I am. I could have gone to those institutions and collaborated with individuals during the summertime to get my PhD without leaving my house. So it really just depends on how adventurous do you want to be during the summertime. There are a lot of places you can go for summer research. if you're just doing the tenure track. But you need to know what your length of contract is, what can you do during the summer, and startup package, and what the startup package can be used for. So, startup packages at an institution like this are in the hundreds of thousands. But in most places, for undergraduate, and some new medical schools are going to be very limited. Just like USC School of Medicine, they're not interested in scholarship as much. Their startup package is very low compared to most other places. Okay. Undergraduate laboratory space is going to be much different. So at a big institution, main campus, LSU, you're going to have huge facilities, right? LSUS, you're going to have very limited facilities. Same system. So again, when you go into that unit, you need to be looking at what's going on. Not only the laboratory space, but even just opportunities for summer teaching and graduate students working in your lab. LSUS, you're not going to have graduate students working in your lab, so you're going to be the one doing the work. LSU Baton Rouge, you'll probably have some graduate students that you can pick and choose from that are actively looking for summer research opportunities. Teaching assignments. This is huge too. So when you're first starting off, everybody's like, I want to teach all these different things. It's actually a big advantage to teach the same thing over and over for the first couple of years. They say usually about 3 times teaching it, you become very comfortable with it and more of an expert. So if you're always changing the topic that you're teaching, one, you're constantly developing course materials for that class. It takes a lot of time away from other stuff. And if you're at a school that harps on scholarship a little bit more, then teaching the same thing is not a bad thing. It actually is going to play in your advantage as a junior faculty. Then when you become tenured, maybe venture out a little bit more. But the first 5 years, don't be volunteering for this year I want physiology, this year I want anatomy, this year I want histology, this year I want cell biology. Well, you've got to remember, you're developing all of the teaching materials for that course. So the more narrow you can make that, especially if you're on the clock, and especially if you've got scholarship, the more successful you can be at meeting that. You can become very good at those few topics that you have and still have time for the scholarship. Job searches in medical education, I just put this up here, knowing I'd be handing it out in case you're not aware of some websites to go to. The INMC, Chronicle of Higher Education, Association of American Medical Colleges, the website. I picked a region. My wife said, I'm not going further north in this place. And I said, okay, how far west are you going to go? Okay, so I know here's where I have to choose from. And I looked at all the schools in that area that I thought would be interested. And you can do that, or if you know you want to go somewhere else, pick those schools, go directly to their website. If you know a school you want to go to, try to get your name in and start talking to people, faculty members there. If it's somewhere close by, start going up there trying to do volunteer lab work or volunteer teaching, depending on what it might be. Okay. You got to be your own salesman, essentially, is the name of the game. And other colleagues. Always use your colleagues. Don't burn any bridges. Be professional. You never know when you're going to need, we have to network to be able to be successful in a group. And these are just my references. So, any questions? I know this was more of a traditional lecture, but to me, when I look at this, it's a very challenging thing to get into. And once you've made that decision, you need to be aware of what you're getting into, because too far down the road, you can't go back to the research, which is what most of us have trained in. And it's okay that you're going down that road, but just be aware of it. Know how to take advantage of it. Know how to take full advantage so that you give yourself opportunities in 5 years if you're not enjoying it as much as you thought you would.
How do you keep your students engaged if you're teaching to a class like an auditorium of 300?
Well, first of all, I haven't put myself in that position. But the largest I've taught to is a little over 100. And that's a very good question. You can do it. You have to be creative with your teaching methods and how you break them up into groups. And so I break them up into groups of 5 to 10, depending on how large they are. But the larger the group, I try to collaborate with other faculty members. So I can do this better at some places. Again, it depends on if it's an undergraduate where faculty, oftentimes at the really small schools like LSUS or something, your faculty are stretched. You're not going to be able to pull in other individuals. But most of those schools are also smaller class sizes. Your larger schools, pull in other faculty members if it's a school that rewards education, the more they're in the classroom, the more they're showing they're in the classroom, that's going to help them anyway for PMT. So don't be afraid to go to a colleague and say, I know you're not an expert in this area, but really all I'm looking for is a facilitator. I've developed all the material, they're going to be doing this in class, and they come in, and so you might have 5 facilitators with you, the expert, answering questions, but yet each one of them can guide them in their discussion. So you can do something called problem-based learning, where we would all be sitting around the group, and I would say, okay, what do we know about this case? And so that's all I'm asking, and then you as the group, you're answering some of those questions. So I'm a facilitator. I don't have to be an expert in the area, but you would want to try to bring them in. Without using other individuals, it's very challenging. Some of them play games in class, for review sessions or something. Or at the end of a clinical scenario that might be 3 hours long, we might play Jeopardy for 30 minutes in a large group, and that really gets them actively engaged as well. But it does get a little rowdy, so you have to be very careful. And always try it out 1 or 2 times in a smaller group, see how it works before you jump in there with something new that you've tried in a 300 student, in a class size of 300. That's very challenging. So, any other questions?
How do you go about formulating a teaching plan and implement back to the teaching plan that kind of cuts out the flowery stuff but keeps what needs to be taught?
Are you talking about more for the knowledge?
Yeah.
Yeah, so I hate to say this, but it really boils down to knowing what the test is for that group of individuals. So if you're talking about medical students, what is on the USMLE Step 1 test? What are the objectives for the USMLE Step 1? So you go to the USMLE, you look at the objectives for your content area, and then you try to look back at some old tests. They're out there. You can go back and look at it and say, okay, these are points that are normally on there. So you really just have to go and find out what those individuals are going to need to be successful in their certification exams. And then you kind of build around that. You don't just give them that information, but you make that as your starting point. So, for example, we know that biochemistry, they're not going to have every step of the insulin signaling pathway. But there are some important parts that you need to get after. And so that's how you start tweaking. Does that make sense? So, and then after that, it's really talking to other professors. So I spend a lot of time in the office of my colleagues that have come before me, individuals that have taught for 10 years, individuals that have taught for 20 years, individuals that have taught for 2 years. And I really just pick their brain. Okay, so how are you teaching it? What are you teaching? What have you found to be successful? Use them. If they're in an institution like I'm at, they're very helpful, they're collaborative, they want junior faculty to be successful. So you have to really take advantage of your colleagues. As a junior faculty, the first time you get in front of an individual, if you haven't talked to those groups of individuals or other faculty members, and you haven't looked at what the end product for that particular group of students are going to be, it's very challenging. Now, if you're just teaching a general anatomy and physiology class at the undergraduate level, 10% of them might be nursing students, the rest of them are just doing it as prereqs for something. It's really up to you. So I just pick a very good textbook and I say, okay, how detailed do they go? And I try to use the textbook as a guide. But if I know I'm teaching a certain set of clinical individuals, medical students, PTs, OTs, I really look at the end product. What are they trying to accomplish with their career? What is their licensing exam going to look like? And what are the textbooks that are in this field looking like? And then I build it from there. And it takes a long time. It takes a couple of months to really research this and talk to the faculty that have experience in those areas, but it can be done. And then as you teach, you start realizing, that really wasn't an important point. I overemphasized that point. Students walked out of there and they couldn't do anything with this. I need to flip that because this is what they're going to see on their exams. Those types of things. But a lot of it's trial and error, but a lot of it is doing your research before you get started on certain topics.
I'll go to the application process. I have a couple of questions. So, first of all, you are on the hiring committee, right?
I was. So in 2012, I stepped off of that committee to take over the first year. So, but I know everyone on the committee, and I talked to them before I came out here, and I said, what are the things that you're looking for? And again, they're really looking, at least at our institution, they're looking at teaching experience and then scholarship to a degree, because they require us to do scholarship. It doesn't have to be basic science once we get there, but they are looking for peer-reviewed publications. But the first most foremost is, what is your teaching experience and what level was it? The higher that level, the better chance that person has of getting additional looks. But anything's going to help. Anything is helpful. So, yeah.
But what document is looked at first? The application letter or CV? I mean, which document is more important?
Which document is more important? I think from the standpoint of the committee, we always looked at the CV first. The application letter was very important, and you wanted to emphasize a few points. But really, if you're emphasizing points and you don't back it up on your CV, it doesn't do any good.
Right.
So you can tell them you enjoy teaching, but you've got to have that history on there. So the CV is very important. That application letter really is an introduction to the individuals receiving it first, but the committee oftentimes will look at the CV first. That letter may go to one or two individuals, and that may flag something in that individual. They'll say, this is one we need to look at based on the letter, and then they'll look at the CV document. But the CV is really the weight of everything that's being looked at. That cover letter doesn't always get seen by, well, everyone on the committee will see the cover letter, but it's really not the most important thing when it comes to your accomplishments. It's like if you were going up for promotion and tenure and you have to provide a CV or a cover letter. If you provide a CV with all your documentation and everything, that's what's going to hold the weight, not that you told me you enjoyed something. So you have to make sure that you guide them in the direction you want them to go. It's like telling your own story in a very short amount of time, but then make sure you have the background to back it up. So, because when it comes down to the discussions that take place, they're looking at your CV. The cover letter gets them interested in your CV, but the CV is what's going to be the meat. And when we're all sitting around as a committee, that's what we're talking about, is your CV, not your cover letter. So again, that's just I was on a hiring committee at USC Upstate, and I was on the hiring committee for USC School of Medicine for 1 year, where we hired 6 individuals. Those are the things for both of those committees. That's really what we looked at. It's not that we didn't ignore the cover letter, but it really directed us on where to go for the CV. It was our first glance. All right, this one is someone we want to look at further, so let's look at the CV in greater detail and let's pick it apart as a committee. But it's always the CV that we pick apart.
Statement of teaching philosophy, how important it is?
Very important, oftentimes for the chair. For the committee, I will look at that, and we will look at that in the discussion as, all right, they've got teaching experience. They're telling me they can teach differently. Now let's look at the teaching philosophy. So it's important, but it really kind of ranks toward the bottom. But if it doesn't match, all of these things kind of have to match. What you're telling me in your cover letter, what you've done on your CV, and your teaching philosophy. They all kind of have to go together. If you have a really nice cover letter, but you don't have a teaching philosophy that is consistent with that, or a history that's consistent with that, that's just telling me you're just telling me anything you need to tell me to get a job. Does that make sense?
Mm-hmm.
So if all of those are matching, I see that you went out of your way to teach at LSUS, and you went out of your way to teach allied health classes. Here's your teaching philosophy that supports some of what you're showing in your CV. Here's your cover letter that supports some of what you're saying. When those three are in line, that's a good application as a package. When they're very independent of one another, that really just says this person can really write well because they're trying to get a job. And we know those are out there, and they're out there. Or this person hasn't had any teaching opportunity. They think they want to go into it, and here's why they think they want to go into it, but they really haven't supported that with any of their experiences. So if you're serious about the education, you do everything that you can to get those experiences, and that's what they're looking for, is how aggressive was this person to try to get experience, even though they're just graduating or even though they're just finishing a postdoc in a hardcore science facility. If someone's truly interested in the teaching side and choosing that as their career path, they're going to have the evidence, one way or another, to support the philosophy and to support the cover letter. So, but if your philosophy can be great and your cover letter can be really well, but if there's no documentation on the CV to support those two, it doesn't matter, because that CV is what everybody's going to go for. Not only that, when it goes to the provost office, because at institutions like we're at, we have to be vetted by the provost office as well as the highest chain of command at the main campus. That's what they're looking at in conjunction. They're not just looking at your cover letter. You need to have that CV to really support what you're saying. And then your teaching philosophy means a lot more because you've had that experience. As little as it might be, or as separated from medical school as it might be, if that's where you're trying to get into, the fact that you have it on there then really says a lot more about the other two. It shows that you're willing to put that time in and you understand what you're getting into. Any other questions? No? Thank you for coming. If I can help, please don't hesitate. I have some cards if anybody's interested.
Thank you very much,
I'm glad to hand them out. But otherwise, good luck and make sure this is what you want to do. It's a blast, but it's also oftentimes not quite as well respected. But that's changing to a degree. But if this is what you enjoy, it's a lot of fun. It really is. So, okay.
Thank you.
You're welcome.